Thank you so much, Howie. Before I start, I'd like to show my gratitude to Gilbert Tang, Professor Sharma, and all the co-directors for the kind invitation to be here in this beautiful city during this time of the year. So thank you so much. I have no disclosures regarding this presentation, but I do have a big challenge to summarize some of these exciting new technologies. How do I go forward? Oh, yes. So talking about adjunctive technologies for TAVR, we should talk about femoral closure, special balloons, pacemaker wires, embolic protections, and leaflet modification. So some of these topics has already been mentioned and covered from my previous speakers, but I will focus my attention in only a couple. It's impossible to go very deep in all these technologies, but this is the landscape for femoral closure. The well-known ProGlide that we generally use two devices when we pre-close for TAVR, but also some collagen-based, patch-based, and membrane-based systems are under investigation in multiple clinical trials. So I think that we will have many options in the future to take care of these large bore approaches. And again, decreasing the bleeding risk without compromising any stenosis in these very diseased femorals. To make our life a little bit simpler, we conducted a small randomized trial in São Paulo using one ProStyle, that's the latest version of the ProGlide, the per-closed system, versus two, because that's the standard of care. And believe it or not, we had 3 times higher stenosis when we deal with two ProGlides versus when we treat this patient with a single one without any bleeding risk. So this is an interesting, while we wait for more sophisticated closure devices, we can use one ProGlide very safely. So the other option as an adjunctive device when we have this very diffuse disease and calcified and severe stenosis is to use the peripheral version called M5 of the Shockwave. So it's been very successful to use in a couple of patients. And again, it's very, very rare that we go transapical or to use alternative access when we have a device like that in your cath lab. So moving forward towards embolic protection, I think in this mature audience, it's needless to highlight the importance of debris going to the brain. I think that the debris migration to the brain during heart valve procedure leads to stroke, 3 to 5%, as you saw in multiple trials, and silent infarcts. So it's very, very common, I would say, in close to 100% of the times that you see by MRI some lesions that sometimes doesn't cause a severe stroke, but cognitive impact with dementia. So I think that we should be very focused on that. The device which is approved here in the US, as you know, is Sentinel. It protects 2 of the 3 vessels that goes to the brain. And again, this is a very competitive landscape with close to 10 devices being tested all over the world. We have a single one approved here in the US, but very soon you're going to have other alternatives. Some radio approach, most of them femoral approach, but it's interesting to see that we're going to have more protection and more data to convince most of the physicians to use these devices to protect the brain. I will just mention 2 that I've been testing in São Paulo, Brazil with my friend Eberhard. The first one is the Protembo by a company called Protembis. It protects the 3 vessels. You see that there's small filter with pores of 60 micron, very quick implantation through the left radial. It's a 6 French device that has minimal interface with the TAVR device, as you can appreciate there, and it's heparin coated. So as a good interventionalist, we should have a quick animation so you can appreciate how this device works. First of all, very simple to prep. You don't want to, TAVR now is becoming so simple that you don't want to create more difficulties. So it goes through the left radial. As you can see, there is a deflectable radiopaque tip that you can easily see by angel, and then it deploys the future. Again, it anchors into the left subclavian, and by using a simple pigtail, for instance, you really touch the whole future towards the three vessels, and again, minimal interaction with the TAVR device that you're going to use, and you can use any kind of TAVR device that will not have a problem. This device doesn't capture physically any debris, but it can certainly protect the three vessels. After a first-in-man study that we contributed in INCOR in Brazil, now they designed the FDA study, which is a randomization against nothing versus Sentinel, and 2-to-1-to-1 randomization with the Protembo device. And again, after this first round, they're going to evaluate the data and increase the number of Protembo. This is what FDA agreed here, Howard. So it will be interesting to see. Another exciting device is the Embolic. Different from the previous one, this device protects not only the brain, but the entire body. So it's a very thin net of nitinol with 150 micropores. And you can see that it works like a women's sock, very flexible. And there is this port here that you can navigate with your system. Perhaps a better explanation in this next slide. You see that there is an expandable access port that you navigate with your TAVR device or balloon to pre-post dilatation. And again, it protects the whole vessel. Who knows if after TAVR you're going to have a little bit more, perhaps renal injury or even peripheral below the knee, some clots going down. So this is, again, a short animation to see how this device works. You see, it's a sheet-based system, and by pulling back the catheter, you release this nitinol net. You see, it protects the three vessels, but also there is like a sock or package that holds the debris. And again, it is a femoral approach. It's not so low profile. It's 9 French, but the same port, you have your pigtail that you use as a landmark to guide your TAVR deployment. And again, minimal interaction also with the TAVR system. And after that, you just pull back. You see that this port is very flexible. So when you finish, you really capture the debris, and then we are sending this to Washington, to Renew Vermani, to evaluate the amount of debris that we collected after using this device. So this is in real practice here in a case that we did in São Paulo, just for you to appreciate how the device navigates, how the TAVR device navigates into the port and doesn't interact too much with the system. When we deploy and after, when you retrieve also the guiding system through the port. So very interesting, and we will have to have more data, of course, to be convinced that protecting the brain, but also the whole body, that will bring benefit to the patients. At least the preliminary looks very encouraging. As you can appreciate, you see much less debris with a Sentinel versus Embolic. So Embolic really captures more debris than with the control arm. So we're very now aggressive to design an FDA study with 500 patients. The control arm has to be Sentinel in this country, but this is a multi-center trial with several centers in Europe and Latin America. As you can appreciate, at the end of 30 days, we'll measure clinical data, but also mechanistical data with the amount of the debris and MRI data. Finally, I think Eberhard mentioned about leaflet modification. We have several devices being tested, and I think that will really facilitate our life when we are dealing with, for instance, valve-in-valve, that we can close coronaries when it's too low, narrow sinus. So it will be interesting to see. Also, devices like this one called Leaflet, that we have approvals in Brazil, not only to treat severe calcified aortic stenosis, but also moderate aortic stenosis. This is a device that can perhaps delay the indication for TAVR. So it's a good valvotomy, as I would call. There is this frame that has blades that you guide towards the leaflets, behind the leaflets. And then there is a nitinol frame that goes inside, and then it creates this like sandwich with the leaflets. So not only it releases the commissures, but also has some scores. You can follow the gradient, of course, as you move step by step. Again, increasing the vessel, the area, the lumen area, but also you can see that you create some scores, perhaps preventing these patients to come back in the next few years. So this is under investigation, and I'm very enthusiastic to see the results. You're very familiar with the basilica approach that was again created by Adam Greenbaum, and we use that to tier the leaflets when you're going to do a valve-in-valve procedure with low coronary arteries, as I mentioned. So by doing that, you see that you can put another valve and it's not going to occlude the coronaries. But more advanced, perhaps, is this system, the shortcut, which also created by a company based in Israel called Picardia. You see that the shortcut makes the basilica approach much, much simpler, again, by tiering the leaflets. And again, we're going to see this device in action more and more often as we move more aggressive towards valve-in-valve, but also TAVR and TAVR. So this can be a potential device to tackle these very difficult situations. You see that this device can tier the leaflets in a more elegant and easier way. So this is my final slide. Again, lots of animations, so not much data, but I think that these adjunctive devices can certainly make procedures much safer, with higher chance of success, less bleeding, less stroke, and perhaps most importantly, shorter hospital stay. Thank you so much.
Thanks. Alex, we're going to move on to Dr. Kendra Grubb, who's joining us from Emory. She is a cardiac surgeon who heads the TAVR program at Emory, and I can't think of a better person to give us ideal perspective on some of the nuances of surgery versus TAVR in our patients, and she's going to talk about optimizing the first TAVR to confer optimal durability and some of the post-TAVR interventions.